So thank you everyone for attending. This is the MSR 034 boost session for gastrointestinal case-based multidisciplinary review. I wanted to thank everyone for attending. I'm Jennifer Wu. I am a radiation oncologist, MGH. On our panel, we'll also have Dr. Anwar, Dr. Baer, Dr. LeConte, and Dr. Kadan, who I will allow introduce themselves.
I'm a radiation oncologist specializing in GI cancers at UCSF.
My name is Spencer Baer. I'm an abdominal imager and nuclear medicine physician in radiology at UCSF.
Noelle LeConte, medical oncologist at the University of Wisconsin, specializing in GI tumors.
And then I'm Motaz Kadan. I'm a hepatobiliary and pancreatic surgeon at the Mass General Hospital in Boston, Massachusetts.
And so these are our conflicts of interest. Okay, so this is our first case. It's a 68-year-old female who presented to the emergency department with right-sided right upper abdominal pain for 1 month, radiating to the upper back. She was treated as an outpatient by her PCP with omeprazole and prednisone for back pain, but without improvement. In the ED, she had labs drawn. They were unremarkable, and this is what her CT scan order showed. So, Dr. Baer, can you describe what you're seeing?
Sure. So this is a select axial image through the pancreas showing focal dilatation of the main pancreatic duct. Those are highlighted by the arrowheads. And whenever you see this as a radiologist, you have to worry about some obstructing lesion. You have to basically prove there's nothing there to obstructing. And then, so looking down, you can see that there is actually a focal ill-defined pancreatic head mass. It's highlighted there. And so whenever you see these constellation of findings concerning about a pancreatic ductal adenocarcinoma, whenever I see this, I start looking for important staging to determine whether the patient's got a resectable tumor or not. So some particularly important findings here is you actually see soft tissue encasing the main portal vein. And then I want to look closely for vessels, and I see SMA looks uninvolved, but there's actually some soft tissue extending and on the axial image and involving the common hepatic artery. If you go one size forward, it shows it right there. So to me, that's very concerning for a pancreatic ductal adenocarcinoma, and the constellation of findings based upon this. Go to the next slide. So
sure enough.
Yep.
No, please keep going.
Oh no, and yeah, that's what I'd write. For us at our institution, our next step would go to US for biopsy because the findings are pretty close to almost pathognomonic for a pancreatic ductal adenocarcinoma.
So sure enough, the patient had an endoscopic ultrasound-guided biopsy, and that ultimately did confirm an adenocarcinoma. So based off of this imaging, how would you categorize this patient? And I'm going to ask this question to both Dr. Kadan as well as Dr. Baer. And I'll start with Dr. Kadan.
Yeah, so I think there have been a few classification systems that have existed, but they largely are congruent in a case like this where there's both arterial involvement and major venous encasement, about 360 degrees by the looks of things here. So to me, this would be classified as a locally advanced. The question of between potentially resectable and categorically unresectable, traditionally we've used locally advanced unresectable, but again, we know that there are some nuances in the way that we treat these today. So I would say that this is a locally advanced rather than a borderline resectable tumor.
Dr. Baer, do you have any?
I think the area between borderline resectable and locally advanced is always sort of danced between the two. it would depend. It depends on the surgeon and then the treatment guidelines. But yeah, I agree that it's given the degree of the venous involvement to be considered for locally advanced.
Great. Dr. Kadan, could you talk about sort of the vascular anatomy around this area, and what do you think of in defining this?
Yeah, I mean, so basically, when you take a step back and look at these pancreatic tumors that we try and resect, I mean, first and foremost, is it on the right side of the pancreas, i.e. would necessitate a Whipple, or is it on the left side of the pancreas and therefore the distal pancreatectomy or subtotal pancreatectomy? And then based on that, the next thing that I would usually evaluate, exactly as you just heard, are the veins, especially the SMV and the portal vein. And again, there you want to sort of, try and categorize this into sort of, venous abutment or total encasement, because this would have implications potentially on the type of vascular resection, repair, or none of the above if the patient was to undergo neoadjuvant therapy. And I'm sure we're going to talk about that momentarily as well. I think that the degree of abutment of venous structures, while important in trying to classify the difference between upfront resectable, borderline resectable, and then encasement and locally advanced, I think is somewhat academic. As long as there's venous involvement, and I think that most people would resort to chemotherapy up front. And then the next thing that I would look at is the arterial anatomy, because this is where it can get a little bit more complicated. So the common hepatic artery is obviously a vessel of interest that we have to preserve but may reconstruct. And then the SMA is the other major one. The SMA is an interesting one because we try and evaluate the left side of the SMA and then the right side of the SMA. Sometimes, unfortunately, with SMA involvement, it's not easy to find out intraoperatively whether or not there's involvement until too late in the case. So it's really important to get sort of an advanced appreciation of vascular involvement in these vessels up front as much as possible from radiology. There are other branches that could be involved, like the first jejunal branch, which is a venous branch. But again, most of the other smaller branches are easier to sacrifice. In general, one that does feature a lot is the splenic artery, splenic vein. In distal tumors, they actually are of less relevance because we tend to sacrifice.
Great. So thanks so much for reviewing all of that. I mean, there certainly is the NCCN formal definitions that, Dr. Kadan had just gone over, but I think, certainly in our tumor boards, it's always a lot of discussion between the radiologists and the surgeons, and even, it's sort of a spectrum. It's shades of gray, not always black and white. So it's really important to have the discussion, and ultimately we always defer to what the surgeons think in terms of how they classify it. As Dr. Kadan said, it probably is less meaningful perhaps for treatment paradigms, more meaningful in the setting of categorization for clinical trials or how you define it for literature, for academic purposes. So moving beyond that, what further imaging would you recommend from this point on? And I'm going to ask this question to Dr. LeConte.
I generally would only need a full CT to stage this patient completely, so CT chest. I don't find PET particularly useful. MRI abdomen would only be if the surgery team felt that would be useful for their purposes, but I do defer to the surgeons as well to establish locally advanced borderline resectable stage.
Dr. Breyer, do you have anything to add in terms of what these additional modalities could add?
I mean, usually the way we do it at UCSF is we get the pancreatic protocol CT and the CT chest in combination. And if there's any indeterminate lesion, we'll go for the MR abdomen, especially if it's going to guide from, if there's an indeterminate lesion in the liver. PET, I mean, I don't think we usually do it up front, if minimally. So that's what we usually normally do it. I can defer to Mikhail too to see what instances he would choose a PET CT, but for us it's usually CT chest and then MR for particular questionable cases.
So thanks, Spencer. With respect to PET, typically in the upfront setting, I think consistent with what everybody else has said, we typically do not use it, but perhaps this will be relevant a little later in the case. But I think one of the big challenges we have is response assessment, especially for those patients who are CA19-9 expressors, and especially later on in treatment when their radiographic response plateaus. So if they are PET positive, sometimes we don't get a risk radiologic response, but this may, in some cases, if they are PET positive and we see a change, it can give us maybe a little more confidence that we have been effective in our neoadjuvant therapy.
Great. So I think we're all in agreement. We at MGH typically just really rely on a good pancreatic protocol CT as well, and then a CT test to stage. So based off of this, what treatment would you recommend first? And I'll give this to Dr. LeConte and Dr. Kadan.
Chemotherapy for us. I think generally we would prefer FOLFIRINOX, but the S1505 trial that was recently reported at the ASCO annual meeting would seem to suggest there may be some more equipoise than was initially appreciated for gemabraxane. So it really depends on the functional status of the patient. For example, what their LFTs look like too, what their performance status is like. But generally, upfront chemo with FOLFIRINOX for us, modified FOLFIRINOX.
Okay, great. And so you answered this question upfront FOLFIRINOX. Is there anything that you feel like differs in any of the other institutions?
Well, I think that S1505, on paper, the two regimens were about the same, so B and C. The pathologic response was higher, actually, in the gemabraxane arm, which was surprising to most of us. When you compare across trials, which of course you're not supposed to do, the response rate seems higher in FOLFIRINOX. So, but it was a very well-done trial across multiple sites in the United States, so probably represents kind of more real world than the FOLFIRINOX adjuvant trial, which many people argued about the CA19-9 eligibility and that these patients seem to do extraordinarily well, overall survival nearing 60 months. So I think it's really a decision for the medical oncologist to decide about the fitness of the patient and their ability to tolerate both regimens. Things like existing neuropathy might factor in if they have chronic diarrhea, those kind of things. So I don't really make up my mind until I meet the patient.
That makes a lot of sense. So sure enough, our patient did get FOLFIRINOX, had 4 cycles, and then the restaging scans demonstrated partial response, but persistent haziness around the common hepatic artery. CA19-9 was also lower. So at this point, what would you recommend? Continuation of FOLFIRINOX, chemoradiation, pancreatic SBRT, or surgery? And I'll give this to both Dr. Anwar and Dr. LeConte.
Sure. And I defer also to Dr. LeConte, but oftentimes we see sort of the debate between two different strategies, either treating till sort of maximal notable effectiveness, and oftentimes, how do we define that? Maybe by a plateauing of both radiologic response and maybe CA19-9. In other cases, and we have done this also at UCSF, we try to just get the maximal amount of FOLFIRINOX in while still preserving their surgical eligibility. So that may be up to 6 months of FOLFIRINOX, and with the recognition that it's hard to get in additional chemotherapy post-operatively.
Perfect. Nailed it. I would defer the question of chemo-RT versus SBRT to my rad onc colleagues, but I think in general, yes, you want to maximize your FOLFIRINOX because nobody tolerates FOLFIRINOX well after a Whipple. So,
yeah.
And I think it's important, FOLFIRINOX, a cycle in the US is 2 treatments. In Europe, a cycle is 1 treatment. It's not totally clear for me if this is 4 treatments or 4 cycles, but I'm assuming this is their first restaging scan, in which case you generally would not want to pivot to radiation until you've gotten at least 4 months of therapy on board.
Okay, perfect. So we did continue, and then we completed a total of 8 cycles of FOLFIRINOX, so 4 months of treatment with improved vessel involvement. And then this is sort of the same question, how long do you go with chemotherapy? And, to Dr. Anwar's point, I think there is heterogeneity in terms of how many cycles people pivot to at this point in time, whether or not 4 months or 6 months, because the adjuvant therapies certainly have 6 months of FOLFIRINOX. Traditionally at MGH, we've given some credit for 2 months of treatment if they get chemoradiation. So it's a total of 6 months of treatment, but not necessarily 6 months of chemotherapy. And I do see even within the Boston area, the different hospitals have different practice patterns that reflect that. So what do you guys typically do at your institutions? Do you do 4 months, 6 months standardly, or you just sort of assess the whole picture and take it case by case?
We shoot for 6 months, but recognize that many patients after 4 months really need a break from FOLFIRINOX. But I would say if the person is doing perfectly well, we would try to get all 6 months in. We generally do not count the chemo rads towards our months of therapy, but I don't think it's wrong to pivot after 4 months. That would probably be more common in my practice. The patients, particularly the neuropathy, is starting to pile up at that point.
Yeah, I agree. At UCSF, it's operating along the same lines, but the goal has traditionally been to strive for the 6 months and then but reassess along the way.
Perfect. So, and at this point in time, we did pivot away, as per I mentioned, our MGH standard. And if we were going to talk about next steps and if it was still felt to have persistent vessel involvement, what would you recommend, Dr. Kadan? What are your thoughts? What are your thoughts?
So at this point, with FOLFIRINOX times 8 and improved vessel involvement, I would say this is where we've had the biggest paradigm shift in the field of pancreatic cancer therapy in the last 10 years. I'd say even 10 years ago, a patient like this probably would not have ever faced the possibility of undergoing surgical resection for that type of tumor. And so now where we stand today is, this is potentially a dramatic response. And the reason that I say potentially is also because we know now from that Ferroni Mass General paper that came out, I think it was in 2015, that it's actually hard to distinguish between fibrosis that represents treatment response versus continuation of tumor cells that are viable on a regular CAT scan, for example. And so what we do and what my approach in this situation would be, as you know, Dr. Wu, is that we would go into the operating room at this point. Well, no, first at this point, we would do chemoradiation. I'm sorry, so I don't want to jump the gun. The question here is going to be between chemoradiation and SBRT, and I think that we've used both regimens. But I'll make the comment about surgical exploration. If you'd like me to make it now, I'm happy to do that now, or we can do it after. I think that our sense in general has been surgically, at least all the way in, to say that in my experience, when the chemo radiation seems to extend over a slightly longer period of time than the SBRT, we probably, I'd say, as a group, have found it a little bit easier to operate on those patients. The fibrosis tends to be less kind of prohibitive for being able to proceed with this. So for that reason, I would personally favor chemoradiation. I think the longer duration of therapy, when you've got this extent of vascular involvement, may have advantages. I'm sure you can make a better comment about that.
Yeah, no, that's, I think, really salient way to look at this, and very consistent with how we look at this at UCSF as well, where we've also more recently begun to treat these patients with neoadjuvant radiation, and after they reach their maximal response with FOLFIRINOX. The debate between chemo RT and SBRT is persistent. The way I often look at this is on two aspects. If sometimes we have an idea of their response, we can kind of take a look at their total tumor burden. Maybe they have CA19-9, and we can see how that's plateaued. Many times we cannot. And so obviously the risk is we don't want to send the patient to an operation where there may be a very small amount of tissue that could be left behind. And if it is, we would like that tissue to have no viable tumor cells in there. And, I think it was really interesting, some of the early pilot alliance study looking at chemo, again, this regimen, but with the full chemo RT. And a handful of patients that went to resection that had less than 5% viable tumor cells actually had extraordinarily good outcomes. And granted, that's just a handful. But when we look at, which regimen can give the maximal chance of killing tumor cells and sort of translating that to which regimen gives the maximum dose, oftentimes we can actually get in more dose with chemoradiation. We convert these into a common denominator called biologic equivalent dose, or BED. And we can actually get more in with a fractionated treatment, because oftentimes these tumors are nestled up against the bowel, which is our dose limiting structure. So we need to be somewhat gentle, but be able to get in a maximal dose. And in study after study in GI, where we've compared the same regimen of radiation to radiation plus chemotherapy, radiosensitizing chemotherapy like 5FU, the results are dramatically different. Almost across the board, the local recurrence rates are cut in half. You can look at it in rectal cancer and esophageal cancer. So there's no reason to think that the addition of chemotherapy is not a powerful multiplier here in radiation. So we tend to defer to for chemoradiation for those patients that still have persistent vascular involvement, especially if the surgeon's very concerned. For patients that may have just a wisp and it's really not a concern, but let's just have extra insurance. Sometimes we'll do SBRT for those patients.
Great. Okay, so we did do chemoradiation and then scans, and we do 50-40 standard fractionation. We do concomitant boost around the vessels that are involved to 5880 with concurrent 5FU. So scans demonstrated, again, improved but persistent vessel involvement. So then what next? And I think this is what Dr. Kanan was referring to, that we've been going in for surgical exploration.
Yeah, so I'm happy to kind of continue on that theme, but essentially, so this is kind of, as I was saying, this is sort of where the huge paradigm shift has happened, is we don't know what's fibrosis from dead tumor at this point. And so we believe that at this point, we should give the patient the benefit of the doubt. Any shrinkage that we see on the scan is beneficial. Even stability, I would say, is clearly no progression, and that to me is also a positive finding. And then, so what we would do in a situation like this is we would take the patient to the operating room. Actually, I should just add that the one very important finding that would drive me towards exploration is a declining CA19-9, which you mentioned that this patient has. And I think that is a critical finding. So that to me indicates that there is some tumor response and hopefully reduced viability. So then based on that, we offer the patient exploration next, not a Whipple, for example, for a case. So what we do is we go in and take a look at these areas that are susceptible around kind of vessels that we might not necessarily want to resect, or would like to know sort of how involved they are. Common hepatic artery, potentially around the vein. The SMA is an interesting one, very hard to actually get in there and biopsy early on to see if there's any viable tumor. If the tumor extends to the left side of the SMA, sometimes you can do what's known as an SMA first approach, where you come in from underneath the ligament of Kreitz and go to the left side and try and biopsy some early segments of tumor. The idea being is that if these biopsies are negative, then you maybe truly only have fibrosis around these vessels. But if the biopsies are positive, are positive, then it means that you might not be helping the patient by attempting to perform a Whipple at this point. Now, I will say that that's our strategy. If all the biopsies that we do early on come back negative, we believe it's all fibrosis and we go ahead and proceed with a Whipple. Most frequently, we'll do this without major vascular resections. On occasion, we'll need to do a lateral side bite of a vein or something like that. On occasion, we'll need to do a more extensive venous resection and repair. We tend to be a little more apprehensive about doing arterial reconstructions. We've learned from other people's experiences as well that these can be tough cases with a much larger morbidity and even mortality especially in the setting of radiation, reconstruction of the arterial tree. We've learned the hard way sometimes that these can pseudoaneurysm in the setting of a pancreatic leak and so on and so forth. Now, I will just say that the spectrum of surgical intervention, ranges from someone will look at the scan and say, nope, still persistent vessel involvement. Let's not even bother going to the operating room. Let's consider additional radiation, for example, to persistent vessel involvement. There's no point in finding out if there's any viable tumor or not. Let's just go in and do major vascular reconstructions, including both venous and arterial reconstruction. And I think that our practice at the MGH really kind of falls somewhere in the middle here, where we do go in, we do explore, we hope to find negative biopsies around these vessels, and then are able to proceed with the understanding that there's been some substantial shrinkage of the vessels. So that's the premise of the operation that we would perform.
That was great. Dr. Baer, I'm going to just ask you a question. I know, a lot of the crux of the issue comes down to, the lack of real, imaging biomarkers of viable disease or persistent disease. Is there anything that you're aware of that, new on the horizon that's getting evaluated, or, what are the discussions and where's radiology at?
Well, there's two questions. There's the assessment of response, and then the assessment of whether there's persistent involvement of vascular involvement. The evaluation of imaging response, there's been some studies looking at biomarkers, either with CT for we can look at changes in perfusion or density of the tumors. And also the other one that people have looked at is PET-MR, where you look at both factors from the MR, from the ADC values, and also from the FDG, where you look at these changes on both the total tumor volume on the FDG, and then you look at the ADC values. And looking at the two together, you can associate a better predictive response within these tumors. Now, the question of vascular involvement, we are still not that great at that yet. And it's something that's very challenging when we're looking at these tumors that come in a butt and at least partially or almost completely encase the SMA, is when they have some response, is there any viable residual tumor? And unfortunately, we still are not great at that.
Okay, great. So, this is just a recent meta-analysis I'm just flashing up here of just FOLFIRINOX in locally advanced that was published in Lancet Oncology. And you can see the median survivals are 24 months. So, for a long time, it was not budging from the 10-month and then the mid-teens. And so this is really a dramatic improvement. And then, to Dr. Kadan's point, the conversion rate to surgical resectability, this is in the meta-analysis. Same meta-analysis was 28% converted to surgical resection with 74% with R0 resection. And then this is just more recent phase 2 study, a phase 2 experiences, including one from MGH with the R0 resection rate of 61%. So this is where sort of there's movement and sort of literature supporting what we've just been referring to. So to that, the Whipple was attempted and performed. Pathology actually showed a YPT1N0 with negative margins. So what next? And I'm going to ask this to Dr. LeConte.
At this point, I would observe the patient, focus on nutrition, focus on neuropathy resolution if possible, mood, weight. Circulating tumor DNA is certainly interesting. It's definitely the new kid on the block. Lots of medical oncologists are very, very excited about it. I think its role in pancreas cancer is extremely unclear, and I'm not sure we should jump on board if we're not sure we're going to help the patient with meaningful outcomes, meaning it's unclear to me if we diagnose someone's recurrence early, if we're really helping them with pancreas cancer. So I would favor observation and supportive care at this point.
Does anyone else differ? I think we would definitely concur with that. Okay. So I'm going to just pivot the case a little bit and say, instead of the initial finding, what if the scans at presentation demonstrated this as an image instead? And I'm going to have Dr. Baer, if you don't mind, just describing what you see.
Yeah, sure. So axial and coronal post-contrast CT images demonstrating a large mass at the pancreatic head-neck junction with complete encasement and occlusion of the portal splenic confluence and extending into the splenic vein. the tumor also extends medially and securely to encase the celiac trunk. So this is a very large aggressive tumor. So involvement of a lot of the major vessels would be considered locally advanced.
Okay. So based on this imaging, how would you categorize this patient? And I'm going to have Dr. Kadan take a look and it was sort of the same question as the last case, but is this case any different, and how do you think about it?
So again, I mean, this is definitely not resectable, definitely not borderline. I mean, this is locally advanced. It's somewhere between C and D. Again, the only thing that I take issue with C and D is basically one of them is kind of asking us to make this upfront comment on how they're going to respond to chemotherapy, which we don't know. I mean, at the end of the day, I would say that if I met this patient in the office today, I would have a less optimistic conversation with them about this scan than I would about the last scan. I think setting more reasonable expectations is a good thing to do here, because this really looks like a large, infiltrative, aggressive, locally advanced tumor. So you go ahead and say that this is categorically unresectable. But, I say this with a caveat that some patients will have chemotherapy and have an absolute blockbuster response. I mean, this scan is a single shot image that's not a dynamic image in time and will not tell us how this patient is going to respond, and doesn't really tell us much more about the tumor biology. In fact, if anything, this has been growing in place without evidence of metastases, potentially. So I wouldn't sort of, jump out to make comments about tumor biology in this setting, and see how the patient does.
Perfect. Okay. So, you just went through all the findings. Let's say that the presacral fat and nodularity, there was some haziness. One question that comes up all the time, is there a role for diagnostic laparoscopy, and when should we be doing them? And I'll ask both I'll start with Dr. LeConte, and then I'll go to Dr. Kadan.
I think it's institutional. I think this is very much a style question and not an evidence question. So we like it to confirm metastatic disease because it does adjust expectations and discussions with the patient, and potentially could get us more tissue if next generation sequencing was something we definitely wanted to do, which, as a sidebar, should be done in every patient with metastatic pancreas cancer or locally advanced unresectable. But tissue acquisition can be a significant issue for this type of cancer. So I would say at my institution, it would be a yes, most likely. But I recognize there are very good cancer centers across the U.S. that do not routinely do these.
Yeah, I mean, I would say that there's a bit of an art and kind of like an individualistic approach in how you would conduct this, because so I would say if CA19-9 is very high, so say 10,000, then I would be comfortable calling this metastatic disease, for example, with the haziness and this type of tumor and this elevated CA19-9. If the CA19-9 is low, then I would be less confident calling this metastatic, and that might be a role for interventional diagnostic laparoscopy. The one thing that I will say about diagnostic laparoscopy is this would be the time for it. It's not after you start with neoadjuvant therapy and then try and go back where the yield is much lower, and then you're less likely to find things, even if they still exist or they may have disappeared. I think the emphasis should be on the timing of diagnostic laparoscopy. And if you are going to do it, this would be the time to execute.
Okay, great. So a laparoscopy was performed. It was negative, and then the patient was started on FOLFIRINOX, just like the last case, and ultimately got 8 cycles. And then after FOLFIRINOX, this is the imaging. Dr. Bear, if you don't mind just taking a quick look and letting us know.
So pre-images on the left, post-images on the right, just showing actually quite pronounced reduction of the size of the tumor in response. In the interval, there's also development of some collateralization, and you can see by the gastric collaterals. But yeah, this examination showed nice response. There's still soft tissue extending around the celiac trunk. So, but overall, a good response to therapy.
Okay, great. So we had at that point a decision and then a discussion, and because of the extent of encasement and collateralization, it was deemed that this tumor was unlikely to be resectable at any point. What next if we think surgery is unlikely ever to be in the cards? Do you think about continuation after 8 cycles, switching to another chemotherapy, or do we think about radiation approaches? So let me go to Dr. LeConte and then Dr. Anwar.
Yeah, I think this is a key case where germline genetics could inform your treatment paradigm. And just as a reminder, the NCCN does recommend germline genetics for every pancreas cancer patient, independent of family history. I think what we've realized since that recommendation came out is that we way underappreciated the rates of BRCA mutations and other germline genetic mutations amongst non-white patients. So you would definitely favor a PARP inhibitor for BRCA or BRCA-like germline mutations. And this would be the setting where you would consider using it as after some induction FOLFIRINOX. But assuming this person does not have a BRCA mutation and they don't have disabling or progressive neuropathy, I would favor continuing FOLFIRINOX for up to 6 months. And then generally I have a conversation about taking a complete chemo break versus continuing on just 5-FU alone. Sort of a maintenance strategy.
Perfect. So let's say, Dr. Anwar, what do you think? I mean, is there a role for radiation at any point for these tumors, or is it one that...
I think so. I think that we often look at the fact that even in the setting of suspected metastatic disease, that although it's a little more controversial there, that local control can definitely affect quality of life if these masses begin to grow again. So a lot of times we sort of even to first order will consider consolidation radiation just to kind of capture the benefit of the tumor and size reduction that we've achieved with chemotherapy. But I think interestingly, we look at choice D, and there's been some emerging and exciting data surrounding potential survival signals with dose-escalated radiation. And there are technical challenges in delivering very high doses next to the bowel, but I think that the advent of whether some more conventional techniques to accomplish this or with the newer MRI-based LINACs have opened the door to getting to traditionally very high doses, which are higher than we would give in prior trials. So a lot of times people refer back to LAP-07 saying that, hey, we did a randomized trial already with chemoradiation after a run-in period with chemotherapy. And so I think there's two things that have changed. Our chemotherapy regimens have become more effective. But on top of that, our radiation delivery techniques have also become more effective. And when we look at some of the data with dose escalation, which I think we're going to get to, there are some interesting signals there. And I think that that's worth exploring, as well as just the pure benefit of local control of such a large mass.
Great. Yeah, so as Dr. Anwar has mentioned, I'm just going to fly through this. There's some data, this is from MD Anderson, suggesting a survival benefit in patients who got a biologic equivalent dose of greater than 70, so dose matters. And this is some newer data from multi-institutional retrospective series of MRI-guided pancreatic SBRT, also with a cut point of 70 gray, showing an overall survival benefit. And this is just the MGH experience, also a different form of dose escalation, but with intraoperative radiation administered, showing 5-year survivals of 8.7% with just dose escalated radiation alone in the absence of surgery. So there is a tail on this curve. 4-year survival is 13.1%. And this is just a comparison of different fractionations and BEDs, across the board. Okay, so that's the end of case 1 and case 2, which was a blend of 2 pancreatic cancer patients as we move to the third case. So the third case is a 42-year-old female with a history of primary sclerosing cholangitis, and she presents with persistently elevated LFTs and chronic epigastric pain. And this is what her imaging shows, her MRCP. Can you describe what it shows, Dr. Baer?
Yeah, so this is an MRCP image showing focal area of narrowing within the confluence of the right and left hepatic ducts with some more mild moderate distal intrahepatic ductal dilatation. Especially if the patient has sclerosing cholangitis, you have to worry about an underlying mass. So I would look closely at the axial images for any obstructing mass. And this is a axial T2 weighted imaging showing a focal mass at the confluence of the left and right intrahepatic ducts, which is highly concerning for a cholangiocarcinoma. And this is post-contrast CT, arterial left, more delayed on the right, showing that focal mass in the confluence of concerning for Klatskin's tumor.
Okay, and then so as you mentioned, that's what the CT showed, a Klatskin's tumor, and the ERCP did in fact show and was positive for adenocarcinoma. So how would you treat this patient for a patient with a Klatskin's tumor? And I'll give this question to Dr. Kadan.
So this is interesting because I see a couple of answers there that I think would be reasonable, and maybe even a couple more to evolve over the next few months, maybe even a couple of years. For example, the GemCis and gemcitabiraxane, especially the gemcitabiraxane, is an interesting concept, and I don't know about its application in Hyler as yet, but we are seeing some promising results with that in other cholangiocarcinomas. In general, if a tumor is resectable, then that's really what you want to do in this setting. And so this is basically what we need to evaluate in this particular tumor. I think that it takes a little bit more workup and study to evaluate the extent of this tumor, because it's important to know things like, for example, to which degree does it extend into biliary radicals and how far up it extends, because that would determine whether or not we're going to be able to get a negative margin on the bile duct. It would be important to know, in general, most of these resections tend to be right-sided resections because the left hepatic duct is longer. About 90% of these actually will be right hepatectomies extended right, because you can sew to the longer left bile duct. But in the setting of this mass, it looked like it was more of a left-sided mass to me, and there's maybe an extended lefting to leave the right posterior potentially. So with that idea in mind, you then start to think about which side you're going to resect, and then so therefore you need to analyze the contralateral anatomy that you'd be leaving behind. And so you need to look at the mass and see, does it involve, if it's a left-sided resection, does it involve the right portal vein and the right hepatic artery? Because those are vessels that you need to be able to spare. And in the setting of the vein, more likely, some of the Far Eastern papers would suggest even the artery that you can resect and reconstruct, or take side bites.
So ultimately, if this patient was seen at a liver multidisciplinary tumor board and felt to be unresectable, and so one of the questions that come up is, there is discussions for liver transplantation in this setting, and Dr. LeConte, can you tell me if you do that at Wisconsin, and when is that something to be considered?
We do it. The patient should be young and fairly healthy and have exactly this type of tumor. We do have a trial for Mets to the liver with colon cancer, but I would say outside of that trial, most of the time, this would be the reason to do the liver transplant. HCC, I guess, being the other reason, but we would definitely have this patient evaluated by transplant.
Okay. So ultimately, because the tumor was found to be unresectable based off of additional imaging that was obtained, that we don't have, that liver transplant was recommended. And Dr. LeConte, can you just talk a little bit about the protocol that you guys typically do?
Yep, we follow the Mayo protocol, so induction, chemotherapy, and radiation, usually with capecitabine as the chemotherapy. It's fairly involved. We see these patients a lot to get them through the treatment, and then they're transplanted at the end of that.
Yeah, so this patient also received chemotherapy per the Mayo protocol, received chemoradiation, and then they traditionally had done an brachytherapy boost. Mm-hmm. But we've adopted SBRT boost instead. And Dr. Anwar, do they do that at UCSF? Have you adopted this?
It's not common to send patients here for transplant, but we often, will, for patients that are unresectable, we'll consolidate with radiation.
So this is just an image of the initial course of radiation and then the SBRT boost right at the hilum, and they get 20 and 5 fractions, or 20 and 5 fractions. And there's lots of literature published on the Mayo Clinic protocol of neoadjuvant chemoradiation and orthotopic liver transplantation for hilar cholangios. Most of these patients, but not all, have a biopsy diagnosis because of the challenges of getting and confirming malignancy in this setting. And this has traditionally been the dosing that has been recommended. We here have similarly adopted chemotherapy first. I don't think that was always routinely the way it was written at the beginning. And the data supports that the 5-year survival is 82% after orthotopic liver transplantation versus 21%, really suggesting that for well-selected patients, it may, in fact, benefit them. So that was just a quick case to analyze something that is a little bit more niche, but that is done at certain institutions. And I think there is a growing number of institutions within the United States that have adopted or explored this Mayo protocol for hilar cholangios. One
I think the one change here might be we're realizing that cholangiocarcinomas are really enriched for certain molecular changes like FGFR2 or IDH1, where we now have drugs, where I would consider using that while we have the tumor in place to figure out if there's an actual response. I think there's a lot of caveats, like you said, to the Mayo protocol and also to the patient selection for this, but we're definitely further along, I think, with options for cholangio than we were even 5 years ago.
Absolutely. I think one of the sobering aspects that have emerged from a lot of this data is those who fall off this transplant list don't tend to be the poor performance status patients and have very limited prognosis.
I would just add that including those patients would give a more accurate assessment of the comparison between surgical resection and liver transplantation.
Yes, and for that reason,
group of patients.
Yeah, the data has been highly criticized for that particular reason. Because in this setting, 71 patients out of 287 dropped off, and this is a larger multi-institutional experience. So that certainly has been one of the caveats for all of this. Okay, so I'm going to just go through one last case because we have probably a little bit more, just shy of 10 minutes left. So I'm going to sort of try to go through this case very quickly as well. A 78-year-old man with diabetes, emphysema, prostate cancer presented with an incidental liver mass on MRI, and his labs were notable for CA19-9 of 24, Hep B, surface antigen and core antibody negative, AFP is 1.2. And this is what his imaging showed. Dr. Baer, if you don't mind.
Sure. So this is the first initial image through a T1 post-contrast showing a peripherally enhancing mass in the right hepatic lobe that's directly adjacent to the intrahepatic IVC. And the net follow-up image shows more delayed progressive central enhancement. Again, you can see that it's directly abutting the intrahepatic IVC. Differential considerations. I mean, it's not enhancing hypervascular that you think about HCC. I'd look at the T2 weighted images to make sure that it doesn't look like hemangioma because it's got central enhancement, not peripheral, nodular, it's continuous. You got to worry about more malignant primary or metastatic tumor process in this case.
Okay.
So, I mean.
So that's exactly what the MRI showed. And biopsy was consistent with adenocarcinoma, CK7 positive, CK19 positive, negative for CDX2, CEA, CK20, TTF1, P16, MSI stable. And PET showed FDG avidity of the liver mass. Dr. LeConte, do you do any additional workup at this point in time based off of the MRI and the PET?
Assuming we feel like we can definitely rule out pancreas cancer, meaning we have good CT or MRI imaging of the pancreas, I think I would feel confident calling this intrahepatic cholangiocarcinoma and treating it as such.
Sometimes it comes up whether or not we should be doing like EGDs or colonoscopies on patients just to rule out liver metastases. How often do you think about that if the PET doesn't show anything?
Not real often, unless the CDX2 or the CEA or the CK20 was positive. I think those provide a lot of reassurance that we're dealing with a pancreaticobiliary primary.
Okay, great. So what would you recommend for the next treatment? Surgery, Gem-Cis, Abraxane, or radiation therapy? So Dr. Kadan, what are your thoughts about surgery for this patient?
Unfortunately, this tumor looks like it's unresectable to me. I mean, it extends very high up towards the IVC. It looks like it wraps around and abuts the IVC. There's at least involvement of the right and the middle hepatic vein. Couldn't quite see the left hepatic vein well, but then actually as you scroll down, it even involves the inflow, the left and right portal vein from the quick glimpse that I got. So I would say that this would be unresectable with extensive inflow and outflow involvement.
Okay. Dr. Lacan, any thoughts about what you would recommend?
Yeah, we would recommend consideration of a trial with Gem-Cis Abraxane. I agree that that's a really intriguing regimen for this type of cancer. And I would want to make sure, it said there were no molecular targets, but I would want to just make double sure that that was a good panel. And we really felt like we ruled out all the usual. So for cholangio, it would be IDH1 and 2, FGFR, and then HER2 would be the ones you'd really want to make sure. And then MSI, which was already run.
Okay, perfect. So this is just some of the chemotherapy data, the ABC-02 trial that established Gem-Cis over gemcitabine, an improvement in overall survival. And you can see these are the response rates of about 26%. And then this is the more recent data with Gem-Cis Abraxane published by Dr. Schroff at JAM Oncology earlier this year with a partial response rate of 45% and a disease control rate at 84%. So I think for good performance status patients, this is what people are getting considered. So he was a marginal, he's older, he was 72, had prostate cancer. So he ended up getting gemcitabine for 6 cycles, had difficulties requiring dose reductions due to neutropenia, nausea, vomiting. And this is his set of post scans. Dr. Baird, can you describe what you see?
Yeah, it shows some interval decrease in size. To the left is the pre and the post. It just shows some interval decrease in size, but there's still some persistent involvement in the vasculature.
So what would you do next? Dr. Kadam, would you say that this is still surgically unresectable?
Yeah, again, I'd have to see the inflow, but based on the degree of shrinkage that I saw with respect to the outflow, I would say that's probably still unresectable.
Okay. So it was still involving both the inflow and the outflow. So what would be the next steps if he, has gotten 6 cycles of Gem-Cis and struggling? What would you recommend? And I'll ask Dr. Lacan.
We would consider radiation in this setting.
Dr. Anwar, can you talk about what thoughts you might have about radiation?
Yeah, I think that, especially given, a very similar paradigm to what we talked about in pancreas cancer, once we reach a plateau, then we want to ideally consolidate that benefit. And if we know that they don't go to surgery, and anatomically we're in a different location, so this can open up SBRT versus a more protracted course of chemoradiation or a hypofractionated course. And that sort of enables a couple of things, especially in a frailer patient that's been through a lot. It obviously allows a shorter time course, but oftentimes we're in the liver, we're not necessarily surrounded or abutting very radiosensitive structures like the bowel. So we can actually go ahead and dose escalate at each fraction and therefore compact the total number of days of radiation into a smaller number of days, but each day we actually give a much higher dose.
Great. Yeah, so there's certainly emerging evidence looking at definitive hypofractionated radiation whether it's considered SBRT or not, but certainly it's also made it into the NCCN guidelines to that end. This is not our patient. That patient is actually still getting planned, but this is just another representative case. And there's data that's also out of MD Anderson. This is from JCO, from Chris Crane's group, and Rhonda Tao, showing how he did a simultaneous integrated boost up to 100 gray, so really pushing dose to these patients. So I think with that, we're coming up to the end of the hour. So thank you very much. Thank you all very much to all the panelists, to Dr. Kadan, to Dr. Baird, to Dr. Anwar, to Dr. LeConte. And I hope you all enjoyed the session and learned a lot. Okay, thank you for joining us. Bye-bye.
Thank you.
Thank you.